Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, and welcome to this Medscape Live presentation on Alzheimer's disease precision diagnostics, a three-part live masterclass. This series comes to us from an independent educational grant from Eli Lilly. This is a three-part series. Today's focus is on amyloid PET, but there will actually be a session dedicated to CSF and another one to plasma. So if you're interested in those questions, I definitely recommend participating in all three. And my name is Tammy Benzinger. I am at Washington University in St. Louis, Missouri. What I'd like to start with is just where do we get this ground truth from amyloid PET, and what have we learned from autopsy studies? What we know is that the end stage of Alzheimer's disease is a diffuse neurodegenerative process that impacts our gray matter, but also white matter structures, ventriculomegaly. And at this end stage, it's not as specific. This could be a brain from a patient with multiple different processes. This one happens to be Alzheimer's disease. The specificity really comes from the neuropathology of two different aggregated proteins, beta amyloid, which forms the amyloid plaque, and tau, which forms the neurofibrillary tangle. And these two pathologies are required for a diagnosis of Alzheimer's disease at autopsy. Now, the good news is we now have the ability to visualize these while patients are still alive. And in the United States, we have three different FDA cleared PET tracers for amyloid: florbetapir, flutometamol, and florbetaben. Here are three examples from their labels, which show us the negative scan example. People talk about this as being the tree in the winter. So you can see just the outline of the gray matter versus the positive scan. When there's cortical uptake, you can see it all filling in, and that's with the plus sign. And you can see all three of these tracers have very, very similar performance, which makes the visual interpretation a lot easier. On the other hand, tau, it's a different protein. And so we have a different type of PET scan that we can do for this. And in the United States, fluortaucipir is FDA cleared for tau PET. And here's the example of a negative and a positive tau PET scan. Negative scan, in this case, very washed out. And a positive PET scan, this is an example of someone with a lot of uptake in the temporal lobes on both sides. And you can see that positive stain as it comes together. Now, the validation for these amyloid PET tracers actually did come from autopsy studies. So we had 29 patients in the original florbetapir autopsy study where patients actually were enrolled from hospice and agreed to get a PET scan while they were still alive and then to donate their brain to science for that validation. And what was identified was that there was an agreement between the visual read on the PET scan and the autopsy in 96% of the cases. Florbetaben also looked at the autopsy results and found a 97.9% sensitivity and 88.9% specificity for neuritic amyloid plaques associated with Alzheimer's disease. And then finally, flutometamol was also found to have about 88% sensitivity and specificity for the moderate degree of neuritic plaques in Alzheimer's disease. Now, we're now in this era where we're talking a lot about PET results versus spinal fluid, CSF results versus plasma. The CSF is measuring the day-to-day production and clearance of beta amyloid in the spinal fluid. So that's telling us if that person right now has the pathologic process ongoing and happening. It also can be used to measure a lot of other things. We're very familiar with doing a lumbar puncture for a patient with suspected meningitis, for example, or other neurodegenerative diseases can also be tested there. So what's nice about that is it can actually give you a picture of more disease processes than just the amyloid PET and has a very high concordance rate with amyloid PET, more than 90%. Amyloid PET, on the other hand, it provides us information about not only how much pathology there is, but where it is in the brain. And what we now have, and this is an update that has happened in the last year, is that the visual reads are now approved in the US from the FDA for quantification as well, which is very, very important because this is how it was used in clinical trials for these new Alzheimer therapies. This is showing us that lifetime burden. Overall, most people accumulate about 3% of the pathology per year. And again, it's very accurate, especially for patients with moderate to frequent amyloid plaque density. Now, how does this come together for clinical practice? If a patient is asymptomatic but has elevated risk, at this time in the United States, amyloid PET is not covered by insurance and not considered appropriate because those patients are not currently approved for these therapies. This may change in the future. There are a lot of clinical trials in progress, but right now, this testing is reserved for patients who are symptomatic and who are suspicious to have Alzheimer's disease, again, because this can give them access to treatment. All right. So, what about tau PET? So, let's go through that. I mentioned there are two different pathologies, the amyloid and the tau. The amyloid PET is positive 15 or 20 years before people have symptoms. And as I said, it continues to grow at about 3% per year. Tau PET, on the other hand, is very closely tied to the onset of clinical symptoms. And so, um, which of these tests you should choose depends upon that clinical scenario. And I do recommend here, you can see in the footnote, there is a consensus appropriate use recommendation that was published last year. So, first of all, both of these are a pretty good choice if the patient is suspected to have Alzheimer's disease. Both of these should be positive for a patient with impairment and a clinical suspicion for Alzheimer's. And that's true, really, regardless of that age. Now, what about if there are some atypical features? Yes, they would also, for Alzheimer's disease, still be positive, even if some of the features were inconclusive. And then in the setting of inconclusive CSF testing, that's where amyloid PET can be a little more helpful because, again, amyloid PET is needed specifically for therapy for an amyloid agent. And if the CSF was equivocal, then they wouldn't be able to go on to therapies. And then finally, um, to also inform prognosis, both of these can be helpful for that as well. Um, in the appropriate use document, you can see there are some different levels of confidence. And what I've highlighted for you here are really what are the scenarios where neither one of these is very well documented or recommended. So basically, if people are asymptomatic at this point in the United States, these are not recommended tests, regardless of their risk, low risk or high risk. There is a little bit of debate that came up for the question of that patient with a subjective cognitive decline and a high risk case, only in the sense that that cognitive testing, if you're suspicious that it was not accurate, or if you don't have access to a highly trained neurologist to do that, then the amyloid PET could come into play. These are not appropriate for non medical uses like medical legal testing, and they should not be a substitute for genetic testing. All right. So how do we explain this to patients because they're asking a lot about which test should I get and how should I approach this? So first of all, um, if a patient has Alzheimer's disease, they should have a positive amyloid test, and that's going to be true for plasma, spinal fluid, and brain PET scan. The advantages of the PET scan is it's very well tolerated. It's about 20 minutes, easy for patients to go through the no needles. It can be done quantitatively and can really link to what was done in the clinical trials, which is very helpful sometimes. It can also be repeated after treatment to see if somebody has responded to therapy, if they're clearing the plaque from the brain or not. And right now in the US, it is very well covered by insurance. So the cost to the average patient, whether they have private insurance or Medicare, is actually relatively low. What are the disadvantages? Well, depending upon where you live, it may not be available. So this is available in major metropolitan areas, but if you're living in a rural area, you may have to travel to a university, for example, to get this testing. And also, if you've had definitive testing, such as a spinal tap, um, getting a PET scan just for the sake of getting another test could actually delay your diagnosis or treatment. And we know that the most important thing with these therapies is starting early because the therapies that we have right now, they slow down the progression of the disease. They don't actually reverse it. So the longer we take working someone up, the more likely they are to have progressive symptoms that we can't reverse. Okay. So, interpreting amyloid PET scans. So, here are just some more examples about that baseline amyloid PET. And what's really nice, what you can see here is again, negative versus positive scans, whether you look at it in color or in black and white. What you can see is that a negative scan has white matter uptake, that internal skeleton, and a positive scan has the white matter uptake, but also the surrounding gray matter. And the patterns of uptake that you're looking for are actually identical for all three of these amyloid PET tracers. The quantification, this was actually used in clinical trials for lecanemab and donanemab to assess for response. And because these tracers can be quantified in different ways by different labs, the Centiloid scale is the way that we can normalize and harmonize between them. And quantification can assist with interpretation of PET scans. Um, in terms of software, there are actually now FDA cleared tools in the United States for performing this quantification. And this is now part of the standard software package that's available in most nuclear medicine departments. And this can actually really help aid in the context of the visual read. But again, the visual read is still considered that gold standard, and that's what the autopsy studies were aligned with. Centiloid quantification is, again, the standard scale. It goes from 0 to 100, and it uses an internal reference region, in this case, the cerebellum. And this may be the most important slide that I'm giving you in that if there's a problem with the cerebellum, then you can get the wrong number for your centiloid. So what do I mean by that? So if you're dividing by the cerebellum, but the patients had a stroke in the cerebellum, or they didn't scan the whole thing, you can actually get false positive centiloid scale. On the other hand, we know that in patients with advanced Alzheimer's disease, there is actually plaque deposition even in the cerebellum. In that case, you're going to get a false negative or low result on the centiloid scale. Um, and also for our patients with an atypical dementia. So let's talk about somebody with posterior cortical atrophy or a posterior occipital predominant, or some of our language predominant variations. If they have an asymmetric uptake, you may have a visual positive scan in these regions, but your overall average, since the centiloid is standardized across these large brain regions, could be low. Now, this is an example case that I think is really, really important to look at and talk about. So, this was a 75-year-old patient, um, cognitive decline, and this was his baseline amyloid PET scan. And what happened was his head position, you can see it's tilted at the time of his scan. And the automated software then applied these regions of interest in the wrong location. So if you look at the top row on our screen, you can see what it's circling as the cerebellum actually is part of the occipital lobe. And then on the bottom row in red, what it's circling as part of the parietal lobe is actually coming out into the skull. So this looks like it comes up with a false negative. So you can see it's phenyloid were very low. Now, if we go and reposition him and do the correct modification, his Centilloid actually now goes to a positive 66.5 when we're using a cerebellar reference region and are looking at the right regions of the brain. So if you looked at this scan, you could easily get the wrong result. Um, but if you actually dig into the QC and pay attention to the Centilloid, is very, very important. So Centilloid scale goes between 0 and 100. And patients who have a Centilloid over 30 is pretty well established as correlating with the established Alzheimer pathology. Now, patients with a Centilloid less than 10, if we aggregate multiple studies, that's generally negative. And then we have what's called this intermediate range or gray zone between 10 and 30. And this is where you're going to have some scans that are visually positive and some that are negative. And there are different cutoffs that trials have used, whether it's a 20 or 25 versus research studies. And again, this is why that interpretation of the Centilloid, if it's between 10 and 30, absolutely has to be in the context of that visual read. And we're hoping that the report that you get back, or that if you're a nuclear medicine physician that you're giving, will accurately explain the findings, particularly in this gray zone. Okay, so what do we say to our patients when we get that amyloid PET result? Obviously, we're going to be talking about that, but it needs to be related to the clinical diagnosis. Amyloid PET can be positive, as I said, 15 or 20 years before someone has symptoms of dementia. So once you're positive in that range above 30, whether that score is 30 or 100 or 150 doesn't actually predict the clinical decline. And it's really important to talk to those patients about this next step and how this relates to their overall treatment option. We now have in the United States two different approved amyloid targeting therapies. And again, these are targeting the aggregated forms of beta amyloid. So our therapies here are lecanemab and donanemab. These therapies are given by infusion, and there are differences in terms of how often you get them and what monitoring there is, which is outside of the scope of this. But to be eligible for either of those, you need to have amyloid positivity. So, what is our appropriate use criteria? I think we go back to that manuscript I was talking about earlier. If you are determining eligibility for therapy, amyloid PET is considered to be very helpful and appropriate, as is tau PET, that later stage of pathology. Now, what if we're looking for response? In this case, it's amyloid PET that is considered appropriate because our treatments right now are targeting amyloid pathology. So we're looking for a change on amyloid PET from an amyloid treatment. So, practical notes. Right now in the US, plasma, CSF, and PET scans can be used to initiate therapy. It depends upon a patient's insurance which one of these is preferred, but amyloid PET was considered the gold standard in the clinical trials. And currently in 2026, probably very well covered in most areas. Now, which of these can be used to assess treatment response? Right now, only amyloid PET gives us that change result. And this was used as part of decision making for switching to maintenance dosing or stopping therapy now. And it's very common for both of these therapies in the US for an amyloid PET scan to be ordered about 18 months into treatment. And this is where, for some clinicians, having the baseline in order to do a comparison to see how much change there is can be helpful. And so this is a very common practice that we're seeing right now. It's baseline PET and post-therapy PET ordered with a request not only for visual read, but for that Centiloid to help judge that response. And it is tricky to look at these after therapy. And I just want to give you a couple of examples. So this is a manuscript that was just published by Dr. Ivanitsa. And these are some examples showing a patient with full clearance or treatment-related amyloid clearance. And you can see this patient started with 123 centiloid. And after treatment, it switches to that skeleton of the white matter only, negative 17 phenolate. So that would be considered complete amyloid clearance. On the other hand, this is the second patient who actually started at 88 phenolates in a positive scan and has persistent positivity at the 18 months. And so that would be a very important clinical discussion to have with that family about whether they should continue with the same therapy, switch to a different therapy, or discontinue therapy. So, take home messages. Thanks for sticking through. Number one, there's a lot of clinical communication that's so important. Managing expectations, the trade offs between the different tests. Yes, the blood test could be simple, but may not be the gold standard and may not tell us how you're responding to therapy. On the other hand, the PET scan may be very difficult to get to or may add to delays in your therapy. Also, again, this concept that the PET scan can help us with identifying the pathology, but also looking for change in pathology after an amyloid treatment. We do need to make sure to prioritize the quantitative analysis. And if you are ordering these studies, it may help to actually state in the order that you need the quantification. Or if you are in radiology or nuclear medicine and you're giving these results, it's very important to include that Centiloid. You can avoid repeat work if you include it up front, but please make sure to do your quality control and give comments, especially if you think that that Centiloid value is not correct or is discordant from the visual read. It's really, really important to include a description of why that is because this directly impacts how that caregiver and family are going to use that result. So, with that, I just want to say thank you to our host at Medscape for putting together this presentation. And I hope you will join us for the presentations on CSF and plasma. I know I'm really looking forward to hearing both of those myself as we think about navigating this complex therapy. Thank you.